It's just lovely.
So let's go through specifics. This is for what? How long?
90 minutes, and we'll edit it down, probably down to about 30 minutes on video, and then a print supplement's going to come from this in September.
And the print supplement is going to be based on what we say, or is it going to be a review or a compendium of what we say?
Do you want that?
90% will be what we say here.
You don't expect this to go easy, do you?
Come to mind after the discussion, and we can add those in. So, the beauty of editing.
Well, but I just want to make sure, because there's two ways to do a round table in terms of the print.
I'd say the
One
same.
is Jason said this, Sue said this.
Yeah, that's how it's going to be.
For the transcription,
Just
don't
what
screw
I
up.
want them to do
The same model
is
as
go around and sort of
DC
do
lines.
There's editing capability. When we jump out of our seat and slap you.
Not in the video here,
Yes,
big
there
guy.
is. They
No
said
way.
they can edit.
We're not editing nothing. We're doing this in one take, 30 minutes.
Right, there's only
One take.
Do multiple takes.
I'm
You're
still
a
close up
pro.
on this gentleman anyways. That's
So Leslie or
The whole time. The whole time. That's it.
she also
That's a
asked
good
you
person
to
to
have
Yeah, smart ass.
a drive or
I hope we're on right now. Peter is a.
Okay, this is a DME round table, right?
Oh my god.
That would be the square table.
I'm so unprepared. Then.
Unprepared. I don't know.
But the DM
Holy crap!
If he
You're
has-
gonna ask
didn't
every
know it's-
question to
Look at this. You're gonna ask
Oh,
me.
man.
No.
Wow.
He's gonna
Yeah,
ask me.
yeah.
You're gonna ask me.
I didn't know this.
What the hell is that?
Okay, a few housekeeping matters, if you don't mind.
It's a long flight from Chicago.
Please minimize the crunching of glasses or the plastic bottles or paper, things of that nature. Cell phones, pages, and other devices need to be on silent or vibrate. Actually, on silent. Vibrate is not good. The microphones will pick up pretty much everything, so you don't have to lean in, you don't have to grab it, just be natural. When we start, I'd like to start with, from here on around, introduce yourself, your name, and a little background, and then when we finish everything, we'll officially start the roundtable.
Cool.
And may I just add, Peter, when you feed questions, would you please note the name of the individual you're asking, just so, again, the transcriptionist can pick it up?
Sure.
So
So you guys smart? I said it. That is kind of stupid. Tribute to Jason.
Right.
Well, what about the other three?
And really stupid, it can come down here.
Yeah,
No,
it's sort of
no,
in between. one
Well,
of the
these
other
guys
three.
get the in-between stuff.
It's in between.
So would you guys rather us not drink at all?
I think it's time.
Usually,
Right there.
Just don't be shaking the glass of ice and
Here.
all.
Ribera is a
some point if we
comparison
need to
study.
talk
It was,
or-
sure, if you want to stop,
Say, wow, that was really dumb.
say, let's stop for a
Don't
minute.
ask me
So ask
anything.
Sinu.
Don't ask me anything about
knows the
results.
results.
Just ask me an idea.
Sinu knows
I don't even know what
results.
Manta is, to be honest.
Yeah, I don't know the results of these
You don't know the
things.
results of Manta?
Ivan's coming out on Tuesday, right?
Something like that, yeah. Do you know if anybody?
You know
do you know?
Manta vibe.
It's a European study or like
Do you know?
results.
Yeah.
There's all the
Yeah, you ask
yeah.
results down there, ask my
Results.
opinion of
I
the
mean, I know
results
those.
after they
Yeah.
talk about it. Just
Pretty
don't
much
ask
the
me
same
anything
as all the
scientific.
others.
Is this a Regeneron?
Yes.
It's not Genentech. I'm just checking.
So we can say nasty stuff about Lisa.
Just checking.
Say whatever you want.
All right, great.
And this is brand names, not
It's not CME.
thank
so
you.
you can say
Anything we want.
It's not CME?
non-CME. Supported by an unrestricted educational grant by Regeneron.
So what if it's off-label things we're talking about? Is
Doesn't
that
matter.
okay?
Yes, you can.
Say anything you want.
We'll take care of that later.
What's the title? Is this really the title? Impact of switching
Working
data?
title. Working.
So obviously all the abstracts, there's like 50 of them that were pulled. That were.
Yeah.
That was Sinu. He's going to
Right.
summarize them for us.
Okay, perfect.
Well, I do have something to say about it, but
Excellent.
Well, you have one of the abstracts.
yes.
Was it a good
Well, you can talk about the
abstract
assess
or a
study.
bad
I didn't know if I could because it wasn't one of the abstracts. That was
Doesn't matter. You can talk about anything you want.
Okay.
So
Yes, that's
you're saying
it's a
off-label things
IST
we'll
that we're
pull out
looking
later.
at.
So this will be a 3 minute.
I just finished.
No,
the
no,
study
he's
on
going to
conversion
qualify
to
it in the intro or whatever,
AI,
saying that there's
submitted.
off-label. Yes,
ISR,
the disclaimer gets
We
put
do
in
that
place.
prospectively.
And Doug, we're going to see this before it goes to print too.
Yeah, anything that's going to be a
But it's
legal
a
problem,
regimen.
a legal issue will be
Yeah, for a
flagged.
regimen that
Yeah,
in
legal.
all
But
volume
they've
Call
been
somebody
pretty
names.
flexible.
not just thickness.
That's good.
We're good. All right, everybody good?
Okay?
Am I talking to that one?
You're just being natural, don't look at it, just,
So we're talking to Peter or
Yes.
anyone else. Okay.
Yes.
you can look at each other. We got everybody in position.
Is there going to be an intro at the beginning of this? Do I need to say thank you? Do I need to thank?
Yes.
Right, you
anybody?
will intro and set it up, but I first want to get an intro from each individual.
Sorry, 1 second. Can we move that back? Peter, this is a roundtable dealing with XYZ, supported by an unrestricted educational grant from John, and we're here at ARVO 2013, and that's all I'm sure you need.
Cool.
You're just supposed to give us your personal background to start, and then you'll do the
Got it.
We want to know who you are.
Where do I?
Just
Can we move that back too?
Right here?
Yeah.
give them
And the bag too.
That's it. Just throw it all.
Perfect. Now I'll leave. Don't be square.
That's it.
Thank you, John.
I think you should stand right behind him.
Okay, but you need to close that door behind them so we don't get any,
I'm gonna
because
stand right
there's
there.
a bathroom right there. Might hear stuff that we don't want in the background.
Or that would be appropriate.
That's right.
Wow.
Sound effect at the right
Sound
time.
effect would be good at certain times.
The flush.
Dr. Kaiser speaks. Flush.
All right.
Are you rolling?
Yes, sir.
Great. Hi, my name is Peter Kaiser. I'm the Cheney Family Endowed Chair in Ophthalmology Research at the Cleveland Clinic Lerner College of Medicine. I'd like to welcome you all to this roundtable that we taped at ARVO 2013 here in beautiful Seattle. And today we're going to be talking about both the diagnosis and management of age-related macular degeneration in light of some of the recent clinical trial data. And I have a very esteemed group of colleagues with me to discuss this. Why don't we go around the table and introduce ourselves?
Thank you, Peter. I'm Jason Slacker. I'm a practicing retinal specialist in New York City, clinical professor of ophthalmology at NYU School of Medicine, and the director of the Digital Angiography Reading Center.
Thank you very much, Peter. My name is Senior Hari Prasad. I head the vitreoretinal service at the University of Chicago. I'm an associate professor, and very privileged to be with this group for this roundtable.
Thank you, Peter. My name is Atul Jain, and I'm a partner at San Diego Retina Associates in private practice in vitreoretinal surgery. And thank you again for allowing me to be here today.
Thanks, Peter. It's also a pleasure to be here. My name is Justice Ehlers. I'm an assistant professor at Cole Eye Institute at the Cleveland Clinic Lerner College of Medicine.
Great. So the whole idea of this roundtable is there's a lot of new data coming out, both comparison studies as well as even here at ARVO, a lot on switching. And what I thought we would do is sort of go over the current landscape of both the diagnosis and management of macular degeneration. So why don't we start with Jason? You see a lot of macular degeneration patients. When a patient first comes in, what are some of the things that you do? What are some of the imaging devices that you use on these patients?
Well, I think the first thing that we have to do is obviously a good clinical examination. Take a good history, find out about the background of the patient, which may play a role in understanding if they truly have AMD. Do a good clinical exam, and then perform imaging, including, for us, photos, fluorescein angiography, and SDOCT, pretty much on all of our patients. Look over all of that, make a determination as to whether, in fact, they do have AMD, if it is exudative, the nature of the pattern of leakage, and then make a decision on initiating treatment.
So, do you think it matters at baseline as much as it did in the past to get a fluorescein?
Well, my practice is to get a fluorescein at baseline and use OCT to monitor therapy, and only repeat the fluorescein if the patient is not responding the way I would expect. But Jason mentioned something very interesting. I have a story just this week of a patient who came to me in second opinion and had hemorrhages in the macula, had some swelling on OCT, never got a fluorescein, and was treated with intravitreal Kenalog for branch retinal vein occlusion and secondary macular edema. Patient came to me, and I saw hemorrhages, I saw swelling, but it didn't look like BRVO. And I got a fluorescein angiogram, and the patient had a beautiful, classic choroidal neovascular membrane. So OCT is critical. I use a lot of OCT, but there is a distinct and very important role for fluorescein angiography, especially to tease out some of these conditions, which may not always be wet macular degeneration.
So, a lot of OCT could show many things that you find on fluorescein angiography, and especially in light of the ACA, Obamacare in the future, where we may be asked to do less and less imaging. Do you think we can cut out fluorescein imaging at this point, or are we not at that point?
I think retina specialists can take very good care of patients with just OCT. The vast majority of patients, in fact. But fluorescein gives us a unique perspective of the lesion. It gives us the geography of the lesion. It gives us an idea of the perfusion characteristics. It gives us an idea where the lesion is located relative to the fovea. When a patient's not doing well, fluorescein can help give us the answer in RP rip, for instance. I would hate to see the day where fluorescein angiography is not part of the management of wet AMD. It really does give me a unique perspective, but I think the vast majority of patients, we can take very good care of them with OCT. In a year, maximum, I do 2 fluoresceins, maximum, and there's some that only get 1 fluorescein in a year. So the burden from fluorescein is minimal, and I think at baseline it does make sense, but I know there are many of our colleagues who don't do it and take very good care of their patients.
So New York, Chicago, not so many Asian patients. Until you're in San Diego, a lot more Asian patients. Do you add ICG at baseline? Is that part of your standard package, or only when you see a problem?
Just going back to FAs real quick, I probably only get FAs maybe on 10% of new wet diagnosis AMD patients and rely mostly on OCT and clinical exam. The only time I really get an FA is if it's an atypical presentation, say like a 45-year-old, or they're unequal disease, one eye has very mild findings and it's advanced, or it's a second opinion patient. Otherwise, FA's really fallen off the map. For Asian patients, like you mentioned, if you're concerned about other etiologies, start out with OCT, and if it looks characteristic, like, it's not polypoidal or RAP or any of the other lesions, probably try anti-VEGF, but if you don't get the expected response after maybe 2 treatments, then I go to FA and ICG. Okay. But unless they fall outside of the range of what you expect, typically go with OCT and clinical exam for the majority of patients.
So you mentioned an interesting thing, which is that you have baseline features in OCT that are kind of helping you figure out management. What are some of the features you're looking for in OCT, for our listeners here that they should be looking at?
You want to compare both eyes. Spectral domain OCT, typically looking for, intraretinal fluid, subretinal fluid, pigment epithelial detachments, things like that. And you base that with your clinical exam if you see like any hemorrhage or thickening, and the patient's own complaint of if they have any metamorphopsia or symptoms. And you put that constellation together to kind of come up with a diagnosis. If there's any inconsistency in those, I think that's where FA comes in, and you're like, okay, well, let's use an FA to help push us one direction or the other. But it's it's relatively uncommon that it goes to that. It's usually fairly clear cut.
So, Justice, you're a big OCT guy. What scan patterns do you use? What are you looking for? Do you track your images? So if you're getting a baseline image, you make sure you do this with tracking?
So, I think for me, I'm predominantly using the Cirrus system. I go to one satellite as well as our main institution. At our main institution, we have essentially every OCT device out there. But it is nice when you have a patient who's going from one place to another to have a consistent device for comparison for doing change analysis and registration. So I do that. I think it's important. I think one of the challenges is that when we see so many patients, how do we quickly make both the correct decision and an accurate decision to give them an efficient way out of our clinic, but also the most appropriate treatment as well. And so, it's challenging often to go line by line through the cubes, which I think is certainly important in some cases. But the way I currently use my scan patterns is I get both the macular thickness analysis with the cube, but also horizontal and vertical rasters and change analysis as well when looking at it.
And when you get the cube, which I agree, I think the cube is a great thing to do you actually go through the cube, or do you rely on your photographer to sort of choose one representative image to decide about treatment?
It depends on the situation. We're actually looking right now at reviewing our scan patterns and what's our sensitivity and specificity, what is our under-treatment or even potentially over-treatment on these. I right now and initially often start out with PRN treatment, so capturing fluid. Some of the results we're going to talk about is the number of times fluids missed. And so it's something that I'm hyper aware of and wanting to look at what can we see with different patterns that allow us for a rapid look. The fact is that depending on your center, you may not have access to reading software, which is the only real way to go through the cube line by line. And so either you're going back to the device or pulling it up. So in most cases, if it's pretty clear, I'm not necessarily going line by line. Again, if you actually look at the thickness map and there's an area that looks suspicious and you don't see signs of fluid, then I will, go to that area on the cube to see what are we seeing there.
And you say you use change analysis, which is great. What are you looking for in a change analysis? Is just colors, or are there certain patterns that you're looking for?
Well, again, when I have a patient who's coming back in, I'm looking at vision, I'm looking at the exam for any signs of new hemorrhage, new edema, and then looking at the OCT for change. When we look at the results that we're going to talk about, under treatment is certainly not something you want to be doing. And so if I see any signs of subtle change in thickness, whether that's 5 microns, less than 10 microns, that's an area that I really want to look at line by line to see is something going on early on. Whether I decide to treat it, often is a discussion with the patient. If it's definitive fluid, that's something that we're certainly going to treat. But I really have found the change analysis to be useful in those regards in terms of really targeting where you're looking back at the scans.
So Jason, you run a reading center. How often is that change analysis, especially in the setting of AMD, correct or incorrect?
Unfortunately, incorrect often enough that it's suspect, and I think being cautious about using just change analysis is important. In our office, we almost universally go through line by line, quickly, mind you, but we go line by line because we just don't rely on either the change in the change analysis or in the central macular thickness numbers. There are many times when things look completely stable, the numbers are unchanged, there's no difference on the automated detection, and yet going line by line, you see a few tiny intraretinal cysts or a little bit of subretinal fluid, and we know that especially intraretinal cysts may be very, very critical in some of these outcomes. So I think it's worth the few extra seconds it takes to go line by line, scan through them, and look for any findings. You can always stop and look, but you can go fairly quickly comparing the two to see if there's a difference.
Jason, do you have reader software in every room?
We have access to reader software through a server, yes. So and
that's often, that's the challenge. At our home institution, we have the reader software, so it's very easy to pull up and go line by line. Whereas running down an entire floor to do that, if you don't, makes it a logistical issue. I think for a lot of practices.
Yeah, I think that really reader software is critical.
Yes.
You really have to have the capability while you're sitting with the patient, going through line by line. And the other key point is there's nothing better to teach a patient. And in fact, some of the patients, I'll walk in the exam room and I'll find the patient scrolling down their images themselves, already looking to say, hey, doc, I think there's a little cyst here on line 18. And I'm like, yep, you're right, let's get a treatment.
Well, in ACA, that'll work very well. You just give the patient their OCT and ask them to read it. Do you need a shot? Yes, no?
Hand them the syringe and they go to work.
I think, for me, I think that patient education tool is also a critical part of it. We have big screen monitors in every room, and actually with every single patient, I go through their OCT at every visit, usually before I examine them, so they're not bleached and they can actually go through it with, and I think it's a really good way to engage them in whichever treatment regimen you're doing.
So in the past, especially with photodynamic therapy and laser, lesion composition mattered. Classic, minimally classic, 100% occult. Is that as much of an issue now, or I know your group, Jason, has really been at the forefront of talking about type CNV types. Which one do you think is more important in the era of anti-VEGF?
I think that when we started with anti-VEGF therapy, I think we kind of tossed out the idea of lesion type as being important, and I think we just merged in the idea of if they're leaking, we will treat them with anti-VEGF therapy. I think as we've gained experience in treating patients, we're starting to see that, in fact, there are subgroups of patients that may do better or do worse with treatment. Patients with RAP lesions, which used to be the bane of our existence, where they were the most difficult to treat with the other therapies that we had, now have become some of the most responsive, albeit may need more treatment, but they've become very responsive. On the other hand, if you see a patient with an occult lesion with features that suggest maybe there's a polypoidal feature to it, even on fluorescein, you start to worry right away that this may be someone that may not be as responsive. It doesn't necessarily change what I do from day one, but it certainly changes what I might say to the patient and what my expectations are going forward, and alert me to pay more attention to that. So I think that lesion type and classification, even with anti-VEGF therapies, it may be important, and certainly as we start to move into a new area of adjuvant therapies, may become very critical to custom tailor your therapy. So I think as retina specialists, we shouldn't throw out our knowledge base on lesion types and characteristics and try to maintain that as best we can.
Does anybody on the panel have any other imaging that they do at baseline besides what we've discussed? Anything in newer imaging modalities or?
For second opinions, and when someone's coming in and they've had multiple injections and they've been resistant, I often will get fundus autofluorescence. When you're thinking, for me, the two sort of masquerade syndromes most commonly you're thinking about are either polypoidal or central serous, and I think fundus autofluorescence, particularly for central serous, can be useful. So that's the one that I will add, not at baseline on the new naive patient who walks through the door, but on someone who's coming in for a second opinion.
Mm-hmm. And what are you looking for in fundus autofluorescence?
Well, often you're looking for patterns of chronicity of fluid there. So it can be both hypo or hyperreflective changes, but you'll often see almost the fluid troughs of what may have been present in chronic fluid. And one of the things we're starting to look at now is the ultra-wide field fundus autofluorescence patterns, and you can often pick things up in the periphery that were totally asymptomatic. Looking at bilateral changes as well can help kind of pin you down with some of your differential in those tough to treat patients.
Do you think there's any role for fundus autofluorescence in light of some of the findings from the CAT study, for instance, about atrophy? Do you think there's any role of getting, say, a baseline fundus autofluorescence just so you can see what changes over time?
I think that's something we're learning about. It's tough because not everyone has it in the office, and we run in again when you're going from office to office what you have access to. I think it's something that we should look at. What our patterns are in neovascular AMD are going to be different than what they are in dry AMD. It's been looked at extensively in dry AMD, but I think that frankly, for looking at the atrophy that we're discussing, OCT may be the better measure of that long term and the easier access, I think, for more people out there.
Does everybody here use any different imaging, OCT scan patterns, or is it all cubes and line scans? Is there any pattern that we should be using besides those?
Go ahead.
I've started looking at enhanced depth imaging as well, because now there's this issue of does persistent anti-VEGF suppression cause choriocapillaris thinning or reduced blood flow to sort of the heat sink of the retina? So I don't know what to make of it, but I'm starting to get a baseline enhanced depth imaged OCT, and then maybe one at the 6-month mark and a year mark, and I'm going to review what that data shows us, which I started about 6 months ago. Yeah. But that's the only other pattern I get.
So I don't do true EDI, but essentially the pseudo EDI on the serous. Again, part of it is a diagnostic thing. Whether I'm deciding to get a fluorescein, I tend to get fluoresceins on the bulk of my new patients. I always get them on second opinions. But again, if you're thinking of not, looking at the choroid, if there's anything atypical, can be useful for things like central serous. And I'm also starting to look at whether the advanced RPE analysis has any utility. In wet AMD, I'm not sure that it does, but it's something that is newer that's out there on some of the newer software patterns.
Great. What about hyperacuity? So I know this is a wet AMD roundtable, but there's been a lot of discussion about hyperacuity devices, NOTEL being one of them. Do you think in the future there's going to be a role for just having a patient come in only when they notice a change in a hyperacuity device, or do you think that's too far into the future?
I don't use hyperacuity testing.
Patients ask about it all the time, but frankly, how reliable is your patient even looking at an Amsler grid? And most of the patients say, oh, I look at it, once a week, and I saw a change 3 weeks ago. And they're like, well, why didn't you call me? They're like, well, I wanted to see if it got better or worse. So now you get a hyperacuity device, which might be a little more sensitive than Amsler grid, but if it's not used, it's you can have a Ferrari in the garage, and if you don't drive it, you're not going to get a benefit from it. So,
yeah, I don't use them. I think as technology, though, becomes more and more integrated into our practices, we're all in the shift or have already shifted to EMR. the information, we have a built-in system where patients can actually, see their charts within our EMR, certain portions of it. So it may be coming that they're going to look at their OCTs in the same way. Although I don't know that those devices are ready for prime time yet, I imagine down the road, especially in select patients, it may become part of our practices.
Interestingly, it's really the non-retina specialists that seem to bring this up more often. Many of us in the trenches dealing with wet AMD that have known diagnosis, it rarely comes up.
Sure. Yeah, it's interesting. I think maybe in the future we'll see more at least dry to wet conversions, because obviously we know from the CAT study that earlier treatment led to better visual gains, something we knew all along. But having some sort of device to get those patients into our offices may be nice.
Yes.
So we live in a very fortunate time. I mean, we have multiple therapies for macular degeneration. They all block VEGF. Why don't we go through sort of what are the differences between our different drugs, and then we'll go through some of the comparison studies. So, Atul, you want to run us through some of the mechanism of action of these new drugs?
So there's basically there's Macugen, which was a specific VEGF 165 subtype A blocker. It's a monoclonal antibody. Then there's Lucentis and Avastin, which are humanized monoclonal antibodies, which are pan-VEGF against 165A. And then there's the VEGF trap, which is a pan-VEGF inhibitor as well, and it also binds to placental-derived growth factor as well. So that's kind of been the evolution. It went from a specific type of VEGF to pan-VEGF blockade to pan-VEGF blockade plus placental growth factor-derived blockade.
So, in your mind, you have these four drugs. How are they different in your mind, just on a MOA type of basis?
I think Atul did a very nice job summarizing the differences between these molecules. There are other things worth mentioning. First of all, the size of the molecule, the molecular structure. Ranibizumab or Lucentis, about 50,000 Daltons. Aflibercept or VEGF trap or Eylea, 100,000 Daltons approximately, and Avastin or bevacizumab, 150,000 Daltons. But there are other differences that are also really worth mentioning. First of all, placental growth factor. Aflibercept or Eylea is the only molecule that inhibits placental growth factor. My opinion is that this helps at levels that we haven't really assessed yet, whether it's durability or in cases that are recalcitrant to previous generation anti-VEGF agents, that extra target, the ability to inhibit placental growth factor may be a benefit of Eylea compared to older generation anti-VEGF agents that don't inhibit placental growth factor. But VEGF trap or Eylea, on the other hand, also has one-to-one stoichiometric binding. Ranibizumab may form dimers, Avastin may form long daisy chaining, and you may see multiple Avastin molecules bind several VEGF molecules. And these differences may confer differences that we're still learning, whether it's in side effect profile, pressure increases, who knows. So we really don't know the clinical significance, but there are distinct differences between the three popular agents that are certainly worth mentioning. But also binding affinity. At the most basic level, there are distinct differences in terms of binding affinity to VEGF.
So, Justice, in your mind, do these differences between the drugs, do they translate into any type of longevity differences?
I think we're still learning about that, and I think that it may vary from patient to patient. I had a patient come in for a second opinion who had around 30 injections in both eyes right before aflibercept was approved. He'd had both Avastin and Lucentis, and essentially he had it down to one of them lasted 14 days, one of them lasted 8. And then when we switched him over, he said this one lasts 21. And so. And the first ones weren't in the order I expected, and so he was and over time we've kept him on Eylea and he's done really well, and now it works for 28. So I think there's some variability from patient to patient. I think that one of the other things, and I think this also may go to some of the affinity binding affinity that each of these drugs have, is there may be a difference in potency, and that may translate some to durability, but it may not be inherent durability, and I think those are some of the things we'll see over time. In the VIEW trials, we saw some of the seesawing of the OCT but the visual results were outstanding, and that didn't translate. And ultimately, this is a chronic disease that goes on for years, and all of our trials essentially are cutting off at 2 years. And so I think it's very difficult to assess what does it mean long term for some of the fluctuations.
So, Jason, we have multiple drugs. We also have multiple ways to deliver drugs. And just on a sort of 30,000-foot view, what are the different ways or dosing regimens that you could possibly do with these drugs?
Well, there are probably 3 established dosing regimens per se. One is what I would call the on-study label approach, which is for Lucentis and for Avastin would be essentially you dose it every month. The CAT data, and I know we'll get into that a little bit more detail, but the CAT data suggested that doing a PRN approach, which is the next one, may not be ideal, certainly with Avastin. So one approach is if you take a look at the results from the Marina and Anchor trials, it was monthly dosing. You got an excellent treatment effect. As soon as you started to cut down on the monthly dosing, you might have seen a little bit of a slide in vision. So on-label study-related dosing. For Eylea, that would be 3 loading doses and then theoretically every 2 months. So that was the on-study label approach. The second approach is PRN, which was popularized by Phil Rosenfeld and the Pronto study, wherein you treat the patient until they're dry, and then you watch them regularly, whether that's monthly or bi-monthly intervals, do OCT imaging, see if there's leakage, and when you see leakage, you initiate therapy again. Some people are using a single injection. Other doctors I know are going another 3 rounds, so again, essentially reloading the patient. So PRN is the second approach, and the third approach is called treat and extend that Bailey Freund first popularized. And treat and extend is based on the idea that in any one patient, in any one eye, there's an interval that you can go before they'll start to leak again. And if you can identify the interval and then back up a little bit, you'll keep them dry all the time. So essentially, give them the loading dose, continue to treat until they're completely dry, and then begin each visit to extend a week or 2 longer. So unlike PRN, which some people confuse the two, PRN, you're seeing them regularly, but you're not necessarily treating them. With treat and extend, if they're dry for every 4 weeks, you would then see them at 6 weeks. So you're giving them just 2 extra weeks without drug. And if they're still dry, you would give them a shot, even when they're dry, and bring them back at 8 weeks. For example, if at 8 weeks they had a little bit of fluid, we know that 6 weeks was okay, 8 weeks isn't, so maybe 6 to 7 weeks becomes their interval, and now you can see them every 6 to 7 weeks, feeling comfortable that they're not going to leak, and monitoring that, in fact, there isn't recurrent leakage. So it's basically on-study, PRN, or the treat and extend approach.
Great. So that's 30,000-foot view. Now I'll sort of dive into some of the study data to see, do any of these dosing regimens work better than any other dosing regimen. So, we've had a couple of comparison studies come out between Lucentis and Avastin. Just going to give us a summary of some of those studies.
Yes. Jason did such a great summary of the different dosing regimens, and I like to break them down between proactive and reactive dosing. Do we wait to see vision loss? Do we wait to see thickening on OCT before we intervene? Versus a fixed dosing regimen like we see in View 1, View 2 first year, the CAT study, the 2 arms with monthly dosing, or even Marina and Anchor, fixed dosing regimens. And I think many of the studies that you're referring to help tease out differences between these dosing regimens, what works and what doesn't work as well. But the CAT study, for instance, provides a wealth of information about monthly Lucentis, monthly Avastin versus both of those as needed. And at the 2-year mark, it's very clear that as-needed dosing regimens do not fare as well. That reactive dosing regimens, waiting for fluid to occur, waiting for vision loss, and then treating, they don't seem to do as well. View 1 and View 2, for instance, in the first year, when you have a distinct proactive fixed dosing regimen, the patients did very well, and whether you use aflibercept or ranibizumab. But in year 2, when we shift over to a reactive dosing regimen, there's a slight tapering off of vision, maybe 1 or 2 letters, but there's a distinct difference in year 2 compared to year 1. So just based on an efficacy standpoint, I think the trials that you're speaking of they do lend support to a proactive dosing regimen. Fixed dosing regimen may have benefits, and it's very interesting to point out that Treat and Extend is a proactive dosing regimen. That it takes a lot of skill, and that's where we practice the art of retina, to customize the treatment for a patient's eye, to really understand what is that dosing interval for that specific eye in that patient. But it is proactive. We don't wait for the fluid to recur. We don't wait for vision loss. We treat before that happens. And if you look at the ASR's PAT survey, Treat and Extend is a very popular regimen that many of us use.
Justice.
The interesting thing about Treat and Extend is I would categorize it as a proactive reactive regimen. It's in that you are being very proactive in maintaining the dry OCT, but at the same time your goal is to increase the interval in between, and ultimately you almost are extending to the point where they do recur. So there is an element of reactivity to it. One of the questions that it'll be interesting to see. Treat and Extend has a lot of pros from a treatment burden, from a patient burden standpoint, from an anatomic standpoint. What the challenge is, we don't have as much data on it. And one of the questions in PRN is, what's the reason for loss? Is it chronic fluid that keeps reacting, or is it catastrophic vision loss in some eyes because they don't have anti-VEGF on board? And does Treat and Extend change some of those catastrophic changes? And that'll be interesting to see over time how those things pan out.
So, you are at the Cole Institute. You hear about CAT on a daily basis, oftentimes when we don't want to hear about it. And, one of the things that Dr. Martin, I think, stresses, which I find odd, because I look at the CAT study, and I would agree with you, the PRN arm did not do as well as monthly. But if you listen to Dan give lectures about sort of the top things that he thinks you should learn from the CAT, he actually doesn't say that. He's more positive about as needed. Why do you think that is?
Well, I think it's because it was the first trial to really show pretty good results with PRN. I mean, at 1 year, the Avastin comparison at PRN was inconclusive, but ranibizumab PRN was essentially equivalent. Now, at 2 years was when it starts to fade. One of the most interesting things coming out of CAT, I think, at the 2-year data was when they split the groups up. And you went from treating monthly for the first year to PRN regimen in half the groups, and they went almost very quickly down to the PRN level of vision. Again, it's not a huge difference between the two groups, but it does beg the question, in a chronic disease, how long do you do this for? Can you do monthly treatment on label? And you certainly can. Will our patients allow us, to do that? And that's where things become really tough. And I think it's why all of us try to individualize treatment in a lot of cases, because this is a 4-year, 5-year, 20-year disease, and we only have data to 2 years. And what we see is at 1 year, yes, and 2 years it's better. And then that also begs the question, are lines diverging? So if you stick with PRN at 5 years, are you going to be even worse off? But I think that's part of it, is that it was really one of the first studies to show that PRN treatment at 1 year, with essentially zero tolerance to fluid and very close following, it does do well. It doesn't do quite as well, especially at 2 years compared to monthly.
And I think it's important to point out that PRN in the CAT study was very different than PRN in all our previous studies. The criteria to treat was much more stringent.
Yes.
And you needed monthly monitoring. The patients had to come in every single month for an examination. So PRN in CAT study was very different, and probably one of the only studies that showed in first year that as needed ranibizumab was not inferior to monthly ranibizumab. But the other perspective I'd like to point out is OCT drying, that really the monthly dosing regimens did better in terms of drier retinas, especially the ranibizumab monthly. But once again, just to reinforce what Justice was saying, that the arms start to separate by year 2. And at the end of year 2, my understanding of the data is that ranibizumab monthly did better than the other groups. Not much, but it did do a little better than, especially the PRN arms.
From an OCT standpoint.
Yes. And,
Well, and it's interesting, from an OCT standpoint, in the Lucentis monthly from CAT, they actually, if you look at the average retinal thickness, were thinner than normal.
Yes.
What do you make of that, Jason?
Well, I think, first of all, look at the OCT systems that were used. I always caution that, remember, we were time domain in CAT, and I raise a big red flag about that. both from a positive and negative point of view. I don't know how much we can rely on the thickness measurements in the time domain systems. I have to, we all discussed earlier the limitations. Had it been a spectral domain system, which wasn't available at the time, we might have very different information. It will be very interesting to see how that plays out. Other studies have looked at that, and some of the other studies of other drugs have employed spectral domains, so we'll be able to look at that as those new data become available. Certainly the thinning is an issue, and that goes directly to the issue of whether there's too much VEGF suppression, whether you can have too much of a good thing, whether you can cause choroidal vascular changes, whether you induce atrophy. I don't really know yet. I'll have to be honest. The data from CAT is at best inconclusive. It is definitely not convincing yet that there is indeed an issue with regard to atrophy, and I think analyses of some studies that have used spectral domain will actually tell us whether or not there really is an issue with atrophy in these patients. I just want to go back to the other issue of the CAT study, and that is that PRN might have fared better had we had spectral domain, because we don't know what we were missing.
Right.
So it's interesting that it was successful in the first year to be fairly close, and it slipped. And the question is, if you were missing 10 or 20% of your patients with fluid, and they had even a small amount that would have been picked up with spectral domain, and had that been applied in the PRN arms, would they have been closer?
Right.
And in fact, would PRN have fared much better had we truly known if there was leakage?
Well, and that's what, it did change, when the CAT data came out, it changed my management for the patients who I was treating in a PRN regimen. Some of them it's difficult after 18 months of treatment and doing well to say, I want to see in 4 weeks. But after watching that, I realized that's the way to do it. That's the only way that really you can be comfortable with that regimented follow-up to do that. And but the spectral domain, time domain question is very interesting because the numbers of, amount of fluid and percentages that were missed by the investigators compared to the reading center was quite high.
Well, and your reading center read the Harvard data set, which in a way mirrored part of CAT in that
Yes.
you had Lucentis both monthly and PRN, but
Correct.
used spectral domain OCT. Is there anything that you can enlighten us from the Harvard data about PRN versus monthly?
Well, not much that's out there at the moment, I guess I would have to say.
Okay.
So there's some limitations, but we'll hear more about that going forward. But having looked at that, I can tell you that the ability to identify very tiny bits of fluid, and again, we're learning more and more that these intraretinal cysts may be important. The very subtle findings that time domain would easily have missed in the methodology that was used may be very, very important, and that's part of what's going to be pulled out now from the Harvard study, is to look at that detail as well as other factors that are going on that you can really identify with spectral domain that couldn't be done before.
Just a quick comment on PRN dosing for almost all the studies. They had very strict criteria. They're it had to be greater than 50 microns of thickness. It had to be X, Y, and Z. Whereas if you saw the patient in clinic and you're okay, well, it's 20 microns thicker, but I can see that there's some fluid and cysts forming. I'm not going to wait another month to have you come back. I'm going to treat you that same day. So PRN it's so regimented that it's almost they're getting worse, but you can't do anything because you're bound by the study entry criteria and guidelines. So I think a treat and extend protocol kind of is a hybrid between the two, which might possibly get the best of both.
Yeah, and I think you all bring up a very important point, which is, we read these studies and we look at PRN, and for instance, in the Ivan study, the PRN group was totally different, right? They did this continuous versus discontinuous, did 3 injections instead of 1, and that one didn't show as much of a difference, and we'll have a primary outcome, shortly here at ARVO. But I think one thing that's missed, especially if you look at Medicare utilization data for macular degeneration, is I don't think the general public is actually doing the PRN that was done in clinical studies. They go, well, PRN works pretty good, then I'm going to do it, but then they see patients at 3-month intervals, but do PRN at 3-month intervals.
Right.
So I think there's sort of that disconnect, and it's very important to understand if you're doing PRN to really, you need to see the patient very frequently for PRN to be beneficial. We'll have some results on treat and extend in the Lucas study, which is the only randomized study going on that's looking at treat and extend. It's also a comparison study, and that should be coming out, I think, later on this year. So it's not too far off that we'll have at least some clinical trial data on treat and extend. So we talked a lot about CAT. There were two other studies. IVAN, MANTA are two other studies comparing Lucentis and Avastin. Did they show anything different from CAT?
So in general, in terms of the one, as you mentioned, Peter, the primary endpoint for IVAN was at 2 years and not at 1 year, and we're going to, I think, on Tuesday here at ARVO, hear those results. MANTA and IVAN both showed essentially similar findings, as from a trend standpoint, that the two agents have similar visual acuity results when compared. And in general, there's some trend towards or significance, depending on the treatment arms, for Lucentis having more of a drying effect on the OCT. The safety signals, also is something that's gotten a lot of discussion. We didn't talk about that with CAT. Each of those other trials were much smaller, and none of these studies are powered to actually find these rare events. CAT had around 1,200 patients, IVAN had around 600, and then MANTA was around a little over 300 patients. And the interesting thing with the MANTA study was in both CAT and IVAN, Lucentis, although again a lot of times was not significant, tended to be just a little bit above with the absolute values. In MANTA, it was flipped, and it's the first one that's come out where Avastin was slightly above, again not significant, in comparison with Lucentis.
Yeah, it was a very interesting finding, and we'll be hearing some more comparison studies as they come out, and hopefully with the meta-analysis, we can really see this. I mean, if you had to just say a one-sentence sort of summary of the comparison studies to date, talking about just efficacy of Lucentis versus Avastin, Jason, what would be your one-sentence summary?
I think that if you use the drugs monthly, they behave very similarly, and when you start to apply them in an alternate treatment regimen such as PRN, there may be differences that are important to the patient, with Lucentis behaving better than Avastin on the PRN basis. And overall, again, as we've seen time and again, regular monthly treatment from a visual standpoint gives the best result than anything we've done to date in clinical trials. And that's why the results of the treat and extend type studies will be important, because we need to see whether that holds.
There's a lot of commas in that sentence.
Yes. You didn't tell me how long. You said a sentence.
So, Justice, you brought us into an area that is obviously one of the bigger questions in terms of the differences in these drugs, which is safety.
Right.
And Dean Martin has said very repeatedly that he doesn't feel there's a safety difference between these drugs. You've read the same study that he is reading from. What is your opinion about the safety between at least Lucentis and Avastin?
I think we don't know the answer yet. I think that we're gaining more and more information. One of the things, when IVAN was designed, it was designed to actually be able to be folded into the CAT data so that they actually could do some of the meta-analysis. And at 1 year, they looked at the safety differences and essentially determined that there were some signals that from a serious adverse event standpoint, which is all comers of serious adverse events, that there was a difference between Avastin and Lucentis. What it meant from a clinical standpoint wasn't clear, and their safety monitoring board determined that it wasn't at a high enough rate to do anything to stop the study. In CAT, when we look at it, the side effects we think about from a theoretical concern, things like stroke and MI, there was no difference between the two. And ironically, in IVAN, when you looked at Lucentis and Avastin in heart failure and MIs, there actually was a statistically significant higher risk in Lucentis compared to Avastin. But the bottom line is the thing that seems to continue to come up is more of this overarching serious adverse events that seem to be higher in the Avastin arms. And what that means, we just don't know, because some of those events haven't been tied to anti-VEGF use, things like hernias, but it is something that's out there. It's something that seems to be consistent. A couple of things that are interesting, Dan talked just yesterday on some of the top 10 things from CAT, and a couple of things that have come out was, one, certainly the IVAN data showed that clearly Avastin seems to reduce serum VEGF levels more than Lucentis, and monthly treatment reduces serum VEGF levels more than discontinuous treatment. From that data, which I haven't seen, but he presented, was that there's no correlation between serum VEGF reduction and adverse events. And so whether or not that's tied in, we're sorting that out. But it's something certainly to continue to watch. The one other thing that the question is this noise? Is in most of these, in the discontinuous or PRN arms, the serious adverse events tend to be higher, and not in the monthly ones. And what that means, again, we don't know.
But correct me if I'm wrong, but I thought the 2-year CAT study showed that serious adverse events were about 30% higher in the Avastin group compared to the Lucentis arm. I think 31% versus 39%, nearly 40% in the Avastin group. I believe that was significant.
It was definitely.
It was
I think
also
that's the thing. It was definitely significant.
PRN.
There's no question. Both at 1 year and 2 years, there's a significant difference. But I think what Dan is saying is that these are not sort of what things we would expect from an anti-VEGF agent. It's not like difference in MI, strokes, etc. It's sort of hospitalizations for GI bleeds and other things. Now, GI bleed may be an anti-VEGF effect, right? I mean, that certainly was seen in the cancer studies.
I mean, I take a humble approach saying that there is a difference, and every study is showing it's not the other way around where ranibizumab is less safe. Venous thrombotic events were triple in the CAT study compared to Avastin compared to Lucentis. And I take a humble approach saying, you know what, we don't know. But the data is showing what it's showing. And I think, we have to advise our patients that there is a difference. We can't explain it, but that there is a difference. And then on top of it, you see what the IVAN data is showing. It's not just a little difference in VEGF suppression systemically. It's a significant suppression. And then on top of it, you throw on the compounding issues. That's a whole other layer of complexity to our choice in advising our patients.
Yeah, I think if you could, look at this, everybody looks at data differently. Obviously, if an Avastin user, you look at CAT and say, well, it looks pretty safe, there's no ATE differences, I'm good to go. But no matter what you say, I think the compounding issues are a big issue.
It's a huge issue.
And certainly if you're going to use Avastin, then make sure you're getting it from a good pharmacy. I know going through Congress right now is a bill to basically certify pharmacies that would be allowed to compound, and they would actually be called compounding manufacturers.
Oh, wow.
They would no longer be called compounding pharmacies. It's something that they would have extra visits by the FDA. They'd also have to pay a fee to the FDA to become a manufacturer. And the interesting thing about the bill is it specifically states, because there's a lot of drugs that get compounded, but it specifically states if you're going to compound Avastin, you have to become a compounding manufacturer. And I think it's good because part of the issue is exactly that, less than scrupulous, shall we say, pharmacies mixing and sending out Avastin. But I also think it's good to have oversight. The unfortunate side effect is the price is probably going to go up because they have to pay the FDA for these visits. So our Avastin will go up. But I actually have heard of several practices that are talking about making clean rooms in their offices to do their own compounding. Have you heard about any of that, or anybody thinking about doing it in their own practice? No?
Well, we're lucky enough we do it sort of within our practice, but not really. I mean, I think there's such a difference in when you're at an academic institution that may have their own pharmacy who's doing it. It's cheating in some ways in terms of a comparison to what the community practice deals with in trying to find a pharmacy that they can trust and all that. I was at a conference in India, and it was very interesting hearing the challenges in a developing country of what they deal with. And someone actually brought up, one of the talks was on how to deal with the Avastin compounding issue, and they do it in their OR. And they have a clean day where they go in and they do it all under sterile conditions. They compound their own, they sterilize it. And it was very interesting hearing essentially, how do you deal with the hurdles of it? The VA system has come up with a different solution. They shut down initial use of Avastin because of the compounding issues and concerns because of an outbreak. And now, at least most recently what I'd heard, I don't know if it's changed, but they were essentially mandating that you use a single vial for every patient, and you're not compounding anymore. It's still a significant difference in cost, but much more expensive than what we deal with. And when you look at reimbursement from Medicare, is not particularly high for Avastin right now either. So it will be an issue if price goes up.
Yeah, and I think all of us, we all use the Avastin. I think we all welcome having some FDA oversight of these pharmacies, because I think that, to me, is the number one safety issue between both Lucentis and Eylea and Avastin. It's the whole compounding.
No doubt.
No question.
Now, what about Lucentis and Eylea? There was one comparison study. Is there any safety differences, any safety signals between those two drugs?
They're found to be essentially equal. no statistical differences and no even like trends with one versus the other up to 2 years out.
Yeah, so the safety signals aren't there.
Right.
The two are essentially identical. So you have this patient. They walk in to your office. Why don't we do like not a one? All right. How about 3 words as opposed to 1 sentence? What treatment regimen do you do for your treatment naive patient? Walks in, has a regular lesion. How do you treat it? You treat and extend. These are your choices, Jason. Treat and extend, fixed, or PRN.
ILEA, treat, extend.
All right.
Great.
That was
Seen it.
ILEA fixed in many patients, but Lucentis treat and extend.
So when you say ILEA fixed, you're talking about 3 loading doses and then switching to Q 8 weeks?
Yes, every other month for the first year, and then treat and extend in year 2.
Okay.
I do ILEA, treat, extend, but if they dry out after the first injection, I start extending them and don't do monthly. I'll go to 6 weeks and 8, and then I'll go up to 10 weeks and maintain them at 10 weeks with ILEA.
So you're doing treat and extend from baseline with ILEA. So if you bring them back in a month, I assume after the first injection, if they're dry, you say you're going already 6 weeks.
Yeah.
So you're not doing a loading dose like Cena. Do you think a loading dose matters?
Well, if you look at like the MANTA study, they and that's the PRN dosing which they did in Austria, looking at Lucentis and Avastin, they found that they gave them 3 monthly loading doses, and that's when they got their best vision. And when you went to PRN, they dropped like 1.5 letters to 2 letters. So I think the loading dose matters to the extent that the best we can measure it with is like OCT. So if the OCT is dry after 1 injection, what are you really loading?
Do you think there's loading dose issues?
I don't know. You talk to Dan, you hear Dan talk about it, and Kat did not do loading for PRN. And again, one of my concerns with not loading is there an element of you could have hit a higher plateau.
Mm-hmm.
And from a vision function correlation, I'm concerned that I might not have hit the plateau that I'm going to hit. I have no data for that, but it's just when you look at all of the trials, that's the curve, and that's where this idea, came from. And I think it was mandated with Pronto whenever Phil designed it that they were going to do the 3 injections, and that's you look at Anchor and Marina though, that's where the curve was. So I tend to do 3 loading. I don't always. It depends. But you tend to have this curve with it. So from my for your patient scenario, is this their other eye's good?
So I'm sorry, the other eye was good. So why don't you answer the question we asked?
So I let the patient choose, and
Let the patient choose. Then you're done.
But from a regimen standpoint, I do a modified PRN where I start PRN, and it's based on how they recur, whether or not I shift them to treat and extend or keep them in PRN. So if they recur with significant edema and vision loss, I shift to treat and extend. If it's a very minimal amount of edema that doesn't have an impact on vision and they don't even notice it and I'm picking it up on OCT, I keep them on PRN.
So you actually will follow patients monthly?
Yes.
And when you say let the patient choose, it's very interesting because we are doctors. We can convince a patient to do whatever we want.
That's right.
It's how we present it. So when you say let the patient choose, how do you what's your discussion that you have with the patient?
So, obviously in the end, you end up guiding their decision 90% of the time. There are people, I tell them essentially that we have 3 drugs that seem to do an outstanding job of improving vision compared to what we had before. Give them as a pretty brief overview that we have 2 that are FDA approved that have the best safety data out there, and also talk with them a little bit about cost. And sometimes that has a big effect, sometimes it doesn't. And if they have no preference whatsoever, oftentimes I start with Avastin and then see what their treatment response is.
So I personally am what you guys are doing. I do ILEA treat and extend from baseline. I actually do it from baseline like you do, where I don't do a loading necessarily. But if you think about it, it kind of is a loading because you do baseline, you bring them back in a month for sure to get injected at a month, and then the next time is either a month or 6 weeks. Yeah, so I missed the loading by maybe 2 weeks doing this method. So it's essentially a loading dose. What about if it's a second eye? Does that matter to you in your choice of treatment? So the first eye, let's say, has geographic atrophy or disciform scar. This is your second eye. Also treat and extend, also Eylea, or do you switch
Yes.
it up?
Yes.
Thank you.
I'll actually answer something a little longer than that. I don't, as I said, I mean, my goal, whether it's first eye or second eye, is to get a regimen that keeps the person dry. So in asking the question, you're making an assumption that that you might be less attentive to a first eye than a second eye. There's an inherent kind of underlying part to that question, and my attitude is I'm very attentive to the first eye because you don't know when that first eye is going to be the better eye down the line. And I mean, we're all dealing with that, where you had an eye that may have walked in 2060 and the other eye was 2020, and now we're 5 years later. The second eye has gone on and gotten atrophy or presented with a hemorrhage or something, and that first eye that you were very aggressive with is now their better eye. So I think that it's wrong to kind of look at it as a first eye, second eye.
Okay.
My attitude is approach it aggressively. And just to go with one of the overarching themes that we're seeing here, since everybody kind of answered a little differently, the problem we face is we are all trying to make decisions on clinical trial data, which takes a group of hundreds of individual eyes, puts them into a group, gets you a mean or median, shows you a curve, and then you're supposed to decide based on that what to do with that patient. And I think that that's the problem with, I get frustrated when I hear colleagues say, I always do this.
Right.
We're not hearing that at this table, but I think a lot of our colleagues, well, I always do this approach with this drug. My patients aren't like that. I don't think any patient is like that. So I think we have to take the clinical trial data, whether it's monthly or PRN, whether it's Avastin, Lucentis, or Eylea, and try to figure out for that individual patient where it falls. And that may be monthly. It may be treat and extend from day one. The hard part is looking at curves for means of hundreds and then applying it to one is very, very hard.
Yeah, for me, speaking of the first and second eye, I think what you're saying, Jason, is exactly right in terms of one of the things I'm always telling them, if they come in and they are on a PRN regimen and they don't want a shot and they have this little bit of fluid, is I tell them, I don't know if this is going to be your best eye. We have to keep it that way. The one flip side to it for me, being someone who often starts with PRN, is that if they come in with their second eye and they already have a disciform scars, I may push harder. And I always tell them that what we know is that at 2 years, PRN is not quite as good as monthly treatment. We don't know where treat and extend lies in the comparison of those. But we know that under treatment, and so I will push them harder towards we should just keep you on treatment. And
the one perspective I'd like to share about patients with bilateral disease is that if you can successfully get a patient to every other month Q8 dosing with Eylea, a patient with bilateral disease, and I have many of these, I see them every month. And they get one eye treated, they get the other eye treated. One eye treated, the other eye treated. But there were times before aflibercept that patients would come in for Avastin or Lucentis every 2 weeks. I had several patients like this in my practice. So the dosing regimen of fixed every other month is a godsend to some of these patients. They can plan their lives, their caregivers bring them to the office, their vacations. So especially in the patients with bilateral disease, the happiness level has gone up in those patients when switching them over to aflibercept. So the predictability of when the appointments are.
do you do bilateral injections?
No, I don't.
Okay.
So do you do bilateral injections?
I do based on patient request.
And so do you do bilateral all drugs? So the reason I ask that is obviously Eylea and Lucentis will be very different than bilateral Avastin.
It depends on sort of where you're at. So in one of the places I have a little bit more control of which lots are used. So for example, I will do it for all drugs. But I'm much more comfortable when I'm able to use separate lots of Avastin, and I'm able to do that at one of the sites. You can't really do that with Lucentis and Eylea because you don't have that control. But it is a concern. And one of the things, I never do bilaterals from the beginning, but I will tell patients if this is something, I'm never going to ask it of you. Mm-hmm. But if from a convenience standpoint, that 2 week it's a huge burden.
It's huge.
And so it is something that I didn't think I would do as much starting practice, and now when you have as many people with bilateral disease, it's a real challenge.
I believe a quarter of retina specialists do bilateral injections. You know, I mean, many of our respected colleagues do it. I have nothing against it. It's just with the concerns in compounding pharmacies, you know, safety issues, and also none of our trials really investigated systemic safety with bilateral injections.
Right.
And you look at the Rise and Ride DME data, and you know, there's some, you know, in the higher dose in 0.5 milligrams, it looks like that there may be some higher systemic adverse events. And so I think until we have more data, I prefer not doing bilateral injections, but I think in the rare circumstance, I'm happy to do it, but with extra precaution.
I would just point out the one maybe positive statistical thing that came out of Harbor was the safety of a 4 times dosage
Yes.
of Lucentis. So certainly it makes you a lot more comfortable if you're doing bilateral Lucentis from a systemic exposure point of view that 4 times the dosage was safe. So giving a bilateral injection the same day seems to be within that safety profile. And I have to say it's the number one thing I got out of Harbor was it was safe. So it's like, good, I can keep doing bilateral Lucentis if I want, and by kind of extrapolation, bilateral Eylea. I think the Avastin issue is critical, and since the first suspicion about compounding issues came up, we've made it a policy to do separate lots. We will not do bilateral unless they're separate lots.
And that was an issue in the outbreaks. You know, there were a couple of bilateral, endophthalmitis cases, and it's devastating.
Same lot. Yeah.
So we all talk about how we use OCT at follow-up. What type of features on OCT are you looking for to decide whether to retreat if you're using PRN, or are they dry in a treat and extend? So what are you looking for?
I typically look for the 2 main criteria are visual acuity exam, then intraretinal fluid or subretinal fluid or cystoid macular edema. If it's just a serous PED, I don't know. I count that as pretty much dry. If it's a fibrovascular PED with some irregularities and some fluid at the tails, then if it's not in the center, I might still extend them a week at a time or a few days at a time. But it's really the cystoid macular edema, subretinal fluid that I look at, and the PED. If it's a serous PED with nothing else, I pretty much say your OCT is dried out.
One interesting thing that came out of a CAT study in terms of the OCT data was they said that the intraretinal fluid over the fovea correlated best with vision. And we've all talked about doing the macular cube. So do we really need to chase, say, some cystic changes 3-4 millimeters away, or is it really and can we just use that foveal scan, which is implied by what CAT is telling us? What do you think there, Jason?
Well, I think that goes to exactly what we were talking about earlier about how tight of a PRN do you want to use. I think that the fact that there is fluid somewhere in the macula indicates that the patient is producing VEGF, that VEGF is being produced. And while today it may be cysts, 1,000 microns from the fovea, a week later there may be cystic changes over the fovea. And I think that it's a clue that there is disease activity in the macula, and I think ultimately our goal is to try to eliminate that, unless you want to see the patient weekly to monitor to see when that shifts over. So I think that's one of the keys, that to me any kind of fluid in the macular area is an indicator of biologic activity, and I would like to suppress that.
And I think, and the other, in addition to that, for me, I'm concerned about hemorrhage. You have an active, if it's a juxtafoveal lesion and you don't have that, you've eliminated the foveal fluid, but you still have a little bit of fluid going on outside that. Your concern, especially in a PRN or a treat and extend regimen, is the devastating submacular hemorrhage. And so if you have ongoing CMD activity, that's a concern. One of the challenges, I think, for any of these on-label regimens is I think all see these patients with a little bit of fluid that never changes, and that might be extrafoveal, whether it's subretinal fluid or intraretinal fluid, and how to deal with that. I find to be a real challenge, maybe over a little atrophic scar of, is that dynamic fluid? Is it related to VEGF? Is it just chronicity? And that, I think, also poses a real dilemma in terms of follow-up and treatment, too.
At what point do you call that outer tubulation versus cystoid macular edema?
I think you can kind of distinguish outer retinal tubulation from edema, but I think the hard part is exactly what was just said was, what do you do with this fluid over a scar or over atrophy? And I mean, what we do is I'll bring the patient back in a week or two just to see if it's a durability effect or if it's therapeutic.
Exactly.
If at the end of a week to 2 weeks, there's no change, and it's over an area that's clearly atrophic on SDOCT, or clearly over an area of fibrosis that you consider to be essentially non-functional retina. I won't that to me is a stable situation because it's not something that's going up and down. You're not modulating that. So kind of go into a little box of, all right, I'm going to pretend that's not there and then look at everything else. But I do want to know that it's not changing at that early stage.
That's exactly what the way I look at it is it a VEGF-driven process? And the interesting thing is I have had, and we're going to get towards some of the switcher data, is that I've had a couple of patients where that part had been stable for a long time, and I wasn't counting it, and I switched them for various reasons, and it went away. Which is interesting.
So you brought up a good point. What on OCT or vision or number of injections do you use in your mind to say a patient is not responding to the treatment they're on?
Yeah, Peter, could I just make one more comment about
Sure.
OCT? In the year 2013, being a retina specialist is difficult because we have such a wealth of data from so many clinical trials and diverse in many ways. And I really believe it's safe to say we have a lot to learn about OCT and how it should guide our treatment regimens. Now, the reason I say this is that you've heard many times in this discussion that we want a dry OCT. And CAT studies showed the more stringent the protocol, the drier the OCT, the more effective the vision gains are. But there's a very interesting finding in View 1 and View 2, where the sawtooth pattern was brought up earlier in the discussion by Justin, where the every other month dose of aflibercept had a fluctuation in OCT between 25 microns early on to maybe 12 microns by the end of the year. But if you really look at it carefully, by the end of year 2, do you know which group had the driest OCTs? The every other month aflibercept group. They had the driest OCTs with less injections. How does that make sense? How do we bring it together? So I think that a little fluid is tolerable. Does it really translate to better vision? Some trials tell us, yes, you have to keep it dry, but then you have View 1 and View 2 where you can get away with less injections. And at the end of the year, even though we see the fluctuations in OCT, they still do very well at the end of year 2.
I would just make one caution. There's some sub-analyses that will be coming out that have indicated that if you do have this fluid and you really subdivide, again, we're looking at big groups, if we subdivide these populations, it may be that if you have fluid, they may not do as well visually. So I would just put a little note of caution that, again, as a group, it may be behaving that way, but when you really look at them carefully, it may be that fluid present at certain time points is probably in the end not a good thing.
So and the other thing with the second year of View, when they went into the CAP PRN regimen, they were still seen monthly, and those patients who were in the Q2 month, if they had fluid, actually could have been treated on a more frequent basis than they were in the first year, which may have been part of the reason why they dried up.
They dried out, yeah. And that's what I'm saying. You have to look carefully at the data. There'll be some more analyses coming.
Clearly
out.
have a lot to learn.
Yeah.
Well, and the other thing I think the sawtooth pattern indicates what we talked about before. It's individualized treatment. There's some patients who just do just fine on maybe every 3 months or every 4 months treatment. And even in the View study, there were patients who needed or should have maybe had injections monthly.
Right.
And so even with EYLEA, where we think it lasts longer, and in fact we have some data to support it, it's individualized.
Right.
And you can't just say, this is how we do it. Each patient is different. Harbor showed it very nicely in the PRN arm. If you look at the number of treatments in the PRN arm, there wasn't a bell curve where there was a certain number where the patients did really well. It was distributed across. I mean, some patients need 2 or 3 injections, some needed 24. And there's no way to find a baseline who's in the 2 and who's in the 24. So getting back to the question of non-response, how do you define non-response?
Single biggest diversity of opinion probably in our field right now. I considered there are different levels of non-response. There's what I call lack of durability. There is what I would call partial response and true anti-VEGF non-responders. The lack of durability is a patient who gets an injection of, for example, Lucentis. At week 2, they're dry. At week 4, they're leaking. I mean, that's someone who's responding. They're not non-responders. They're simply leaking at a time that you would normally expect them to be dry using Lucentis. A partial responder is someone that has less fluid, but never goes completely dry even at 1 or 2 weeks, and then kind of has that curve of going down and then coming back up again. And then there's the true non-responders, and I think that's a small minority of our patients that don't do anything, that you give them an anti-VEGF and it just kind of the retina waves at you and just doesn't change. I think that's a small fraction of the patients we deal with. I think most patients with any of the drugs show some response, and then the question becomes which one's going to work better for that particular disease pattern. So I think that's kind of the pattern. As far as what constitutes non-response, cystic changes, subretinal fluid, and as Justin mentioned, we're starting to get into the area where maybe now that we have EYLEA, we can start to even talk about the RPE detachments and some of these more chronic fluid situations. So I think we can look at all of them as potential ways to look for to fit into these three categories.
One of the interesting things, as we talk about what defines response, one of the things that we don't talk about is vision, because it isn't really part of it. But when we talk about how are you doing, in the end, what really matters is vision. But we can have people who respond brilliantly to the drug, and the vision doesn't budge, and that's something also that, as you think about, when I think about switching, drugs and all that as well, it's the one other part of it that the patient comes back in the most with, and it's the hardest to predict in a lot of these patients and what effect that has.
But you can also have those OCTs that look scary. You're like, PED, subretinal fluid, and you're 20/25, and
Right.
like it doesn't budge, but you're like, you're doing well. Do you call that, it's a failure patient to treatment on OCT, but their vision's still 20/25 and the goal is maintenance of vision? I mean, I would say, hey, let's not rock the boat and let's keep you where you're at. So there's also that flip side.
Right.
Mm-hmm.
So, Justice, you have a lot of patients who start off with Avastin. At what point do you say, oh, they're really not responding to Avastin? Is there a time point, or is it really a gestalt thing?
Again, I think the thing you have to remember is the heterogeneity of our patient population. There is no, I think, cut and dry definition of at this point we know you're not going to respond, because there are patients, and we'll talk a lot about, if you treat them monthly, that at month 6 or month 7 they might become dry. From a comfort, so in the end, I think it becomes more of a comfort and judgment call on your standpoint on any of these drugs. What are we seeing from an effectiveness standpoint? And for me, if by 3 months, honestly, at a month, I'd like to see a little bit of response. I don't necessarily want to see them dry, but in most patients, you come back and you see improvement. If it's 0 response, I start to think about my diagnosis. And I think that's the other part about the non-responders is then you really want to be sure you've got the right diagnosis of choroidal neovascularization, whether and hopefully that it's whether it's AMD or whatever you're looking at. But for me, if at 3 months I've gotten my response is suboptimal, both from a vision and anatomic standpoint, that's when I start thinking about changing what I'm doing.
And what do you change to?
Most of the time, I'm changing to EYLEA at this point. Again, I talk with the patients about it. I've had patients who will say, I want to go with the one that's been around the longest, that has the greatest track record, and then we go with Lucentis. And others, it's funny, I had one patient who, she's been treated, she's been on monthly Lucentis for the last 2.5 years. And when EYLEA came out, I talked with her about it, and she said, one of my friends had an issue, and I don't want to switch. And she came back about 2 months ago, and she's had persistent fluid, so she's a suboptimal responder, but she has disciform scars in both eyes. We're keeping her at 2100 in the one eye. She comes back in, she said, I want to try switching. And I said, oh, that's great, we'll try it and see. And she said that same friend is doing great on it. And so there is some, for me, anytime you talk about switching, as Atul mentioned, you are rocking the boat and you're changing a direction, and you want to have the patient engaged in that decision.
So you guys all start with EYLEA. Do you switch from EYLEA to Lucentis or Avastin?
I've had a couple. And I think, and again, it goes to the fact that there never say always or never say never. Sure. There are going to be individuals who are going to respond for whatever idiosyncratic reason to one drug better than another. I have a couple of patients who were started on EYLEA and seem to be doing better on Lucentis. So there will be individuals. I've had a lot more where I've converted from Lucentis or Avastin to EYLEA and seen a fairly dramatic response. So I think that, that's the reason I start with EYLEA. I kind of weigh all three and say, all right, this one seems to do a little better than this one seems to be a little safer than this one, therefore I might as well start with the one that I think is maybe better in some people. but I'm not married to one drug, and if it looks like they're having a suboptimal response to that, I will try a different one. And to me, it's not going up or going down. It's just shifting, and be fortunate that we have 3 tools to choose from.
Yeah.
I did. There's a study I submitted. It's data. I can't speak specifically about it, but I found that we say there's a complete responder, their OCT dried out, exclude them. And there's now, if there's a failure patient, exclude them. Now we got this group of incomplete responders that have some fluid. We don't know really what to do, and they're on bevacizumab or Avastin and Lucentis. And when I converted them to Eylea, I found that I could get mild improvement in vision, but the take-home point is I looked at it at 6 months out. It was basically 2 weeks further that they could go without an injection than they did on either of the other 2 drugs. So what I learned from that is switching them to Eylea kept their vision the same or slightly better, but they got a 2-week extra break between treatments from me. And I think that's huge, because if they were coming every 4 weeks, it's 50% less they have to come in, transportation, and all these things are a huge benefit.
Yeah, and I think there's one other group too for me that I see is that those who have appropriate response at the beginning, and over time that response attenuates. And I think that's a different, it may or may not be, I sort of suspect it's a little bit different issue than the people who are suboptimally responders from the beginning.
Atul brings up a very interesting point about suboptimal responders, is that, first of all, we have defined it from the patient's perspective and our perspective. Okay, that is 2 completely different viewpoints, so we have to communicate with our patients about what they're looking for in terms of therapy. But suboptimal responders, the funny thing about it is that there's so much discussion about defining what it is, but when we see it, we know it. And it's either the vision, it's based on visual acuity, it's based on the dosing frequency is not as good as we would like, or imaging. Okay, that's really what it comes down to. And so because of these variables, the 3 different variables I spoke of, patient's perspective and the clinician's perspective, it's a very hard thing to define. But really the options are so limited. Okay, number one, you can increase the frequency. You can, maybe go every 2 weeks of Avastin, 2 weeks Lucentis, but the burden is so ridiculous. I mean, it's a very, very high treatment burden. You can increase the dose. Okay, look at the Harbor study. Really showed no effect doing quadruple dose Lucentis. A SAVE study showed some possible benefit. Or you can switch to aflibercept. And, those really are the options that I see. You asked about patients I start off on Eylea, what I do if they don't respond as well. I back up from every other month dosing to monthly dosing, because View 1 did show a benefit, a statistically significant benefit of monthly aflibercept over Lucentis monthly. So I do utilize that at times, and sometimes just pushing forward with treatment, you will reach your end goal. But this is a complex issue. There's no doubt, very controversial, a lot of discussion. But Jason, gave a very nice description of suboptimal response. Probably the best definition I've heard so far on this topic.
You let me say more than 3 words.
Yes, and that helps.
Well, here at Arvo, there's going to be, and there has been in other previous meetings, a lot of sort of case series recall of people who are on Avastin or Lucentis being switched over to Eylea. What's sort of the general summary of how those patients did?
Well, go.
No, go ahead.
So our superstar resident, Khushbu Agarwal, she's a resident in Mass in New York, New York for fellowship. She spearheaded a study looking at 35 patients at our center who we could not treat and extend beyond 6 weeks with Eylea, with Lucentis or Avastin, and switched over to aflibercept. And what we showed was an improvement in vision, drying on OCT, and looking at VFQ-25, an improvement in the patient's perception of their disease, mainly driven by decreased visits. But I just for fun, I looked at 15 different Arvo abstracts that are presented here at Arvo at this meeting, and just to qualify it, there's great variability in the studies. Who are included, how suboptimal responders are defined, inclusion, exclusion, how they were imaged, but they all included suboptimal responders to Lucentis or Avastin. And this is what I took from it. There are 15 abstracts. Only one single study showed that vision and OCT did not change. Okay? 3 studies showed that vision didn't change, but OCT improved. 1 study showed that vision improved, but OCT stayed the same. But 10 of the 15 showed that vision and OCT both improve. Now, you have to be very careful what you derive from this, but the key message is that no one had a decrease in vision or a decrease in OCT. So I think if we switch to aflibercept from older generation anti-VEGF, we can do so safely. And there is a distinct population of patients that do respond. Who knows why, whether it's placental growth factor, tachyphylaxis, I mean, all sorts of reasons, or maybe higher binding affinity to VEGF. But I think we can do it safely, and maybe even a benefit in terms of dosing regimen.
Yeah, I think, looking over, as Sinu said, there was a wide variability of the type of studies that were submitted. By far, the vast majority of them are retrospective. And so drawing any sort of significant conclusions from these, I think, are difficult. We're right now doing a prospective study that we're looking at the Cleveland Clinic that one of my partners, Rishi Singh's running, and we're starting to learn some of that data coming out of it. But what I saw as sort of the unifying sort of commonality of these is that anatomic improvement. That seemed to be pretty universal. And the vision was a little bit more variable as I looked at them, but again, when you go retrospectively, it's so difficult to interpret that because you don't know when is the starting point. Were they going from PRN dosing to regimented EYLEA? But the clear commonality that I saw was that the anatomic change was pretty distinctive. There was there was one study that actually, I think it was like 80 eyes, and then they looked at the subset of 12 eyes that lost vision when they first changed. And of those 12, the bulk of them actually came back to baseline. There were 5 that didn't, but every single one of the 12, I think, improved from an anatomic standpoint, which probably lends itself to the chronicity of the disease and is probably actually, and I've had these patients, one of the things that when you talk about switching, I'm always cautious about is, they have this little tiny bit of subretinal fluid and you flatten them out and their vision goes down. My hope is at that point the vision stays stable because you've now hopefully stabilized the disease, but clearly it seemed like in the bulk of these abstracts, the anatomic change was there.
And the study he's talking about from the Cleveland Clinic, Rishi's study, we prospectively followed, I think it's about 26 patients that were enrolled, and we put them onto a fixed dosing regimen of EYLEA, 3 injections after switching them, and then every 8 weeks. And at the 6-month time point, the patients gain about 7 letters of vision, which is, you don't expect to see such a large improvement in such a short period of time. So,
and especially the hardest to treat patients.
Right, yeah, exactly.
Chronically treated patients,
Yeah.
exactly.
Why do you think this is, Jason? Do you have any? You're one of those brilliant thinkers. What's the reason for this?
I think that there's a lot of things that were thrown around. I think it's already been mentioned, some of the ideas. Tachyphylaxis makes sense for people that have been on chronic therapy, but I have patients who were on 1 or 2 doses of Lucentis or Avastin and then get switched, and they seem to respond dramatically, so I can't consider that a tachyphylaxis issue. I think the placental growth factor is something to consider. We did our own prospective study, and what we found is that a majority of the ones that are our chronic patients have features of a thick choroid that might imply some underlying central serous. They have some patterns on ICG that suggest polypoidal. So many of the ones that we're considering poor responders have these other factors. And if you look at the literature, they've done studies on some of the growth factors or angiogenic factors in AMD, and placental growth factor never seems to be on the list. It certainly is on the diabetes list, so I look forward to seeing the differences in diabetic retinopathy among the drugs. But for AMD, it's never been considered to be a big player. But that's in, quote, typical AMD. The question is, what about the ones with central serous components? What about the ones with polypoidal components? Maybe placental growth factor does play a role here. That's one possibility. The second may be the binding affinity. This tight binding affinity that EYLEA has. If you've got a lot of drug, it doesn't matter what your binding affinity is. If you have 1,000-fold of Avastin, Lucentis, and EYLEA all going after the VEGF molecules, it doesn't matter what the binding affinity is. But as soon as the drug levels come down, it does become more important of how much free VEGF is floating around. And if the binding affinity is tighter and longer, it'll hold the VEGF and prevent it from hitting its receptor. And if you think about it, most of our bad responders have RPE elevations. Most of them are occult type CNV anafluorescein. Most of them have at least some degree of sub-RPE fluid. And if most of the CNV is under the RPE, if you think about it, from the moment we inject any of the drugs, regardless of the size of the molecule, under the RPE is the lowest concentration of drug from day one. So that would be the area where binding affinity might play the biggest role. So it may be that something as simple as the affinity of the molecule for VEGF may be the driving factor here. The simple fact is, great ideas. I sounded really good telling you that. We don't know.
Yeah, I mean, that was, anecdotally, when EYLEA first came out, it was those patients that were so striking for me just in clinical practice. And it is the one subset that when a patient comes in primarily that I am treating with EYLEA off the bat, is those are patients when they have a lot of pigment epithelial pathology that's a component. Those are the people who, if they're asking me what do I think is, what would I recommend, that is where I often will consider starting with EYLEA as primary therapy.
Great.
We
Well, I
should
think
also,
we've. Go ahead.
Oh, sorry. We did keep in mind that it's like a one-to-one binding with EYLEA as well as the other thing. That whereas the other ones with Lucentis and Avastin, you can get dimers or clumps. So if you have one-to-one binding and you've clumped all these molecules, you might not have any active molecules left to bind VEGF, X days later. Whereas if it's one-to-one and that one hasn't found its partner yet, it could still float around and find something to bind to. That could be another reason why we're seeing better effects or longer duration as well.
Great. So we've spent a lot of time today talking about the diagnosis and treatment of macular degeneration. Any last-minute comments, future directions that you're looking forward to?
I'll start off. Number one, we have a long way to go with this disease. I remember when the Lucentis data first came out, and I was standing next to an investment person, and they know that that I'm involved in a lot of research, and they turned to me and said, "So, we're going to be pretty bored now that we have a problem solved in AMD." And I just kind of looked at them and said, "What are you talking about?" 90% less than 3-line vision loss at the end of 2 years is great data. I mean, that's wonderful. But that means 1 out of 10 patients we see is going to lose 3 lines of vision. 35% 3-line gainers is great, but that means 70% of our patients aren't gaining vision. So great first step, but there's a long way to go. We need to control the disease. We need to control fibrosis, prevent atrophy, restore RP function. I think we've taken a huge step forward, but I'm looking forward to the next big thing to come along. So thank God at least we can control our patients with these drugs. Now give me the next thing.
Well, thank you all for being here. ARVO 2013. We look forward to some data that's coming out at this meeting, and we'll hopefully have a roundtable to discuss that in the future.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks, guys. Good
Great
job.
job, Peter. Very nice job.
Natural.
These are. I don't know if you're looking at.
Hold it. Oh. There you go.
God.
Oh, let's hear it for Peter. Oh, Peter, very nice. Nice job, Peter.
I'm just glad you found the round table room.
Yeah.
That was a good
I was
start.
like, where's the
confusing
round?
part
Where's
was
this round?
it's not round.
Well, I walked, like I said, I
know.
walked in. Where's the round table? She goes, it's right there.
Yeah.
No, I'm serious. There's a round
Wise
table
guy.
in the lobby.
Yeah,
What's
it's
my
smart
name?
ass there.
You go, really? That's really what you want to show me?
Yeah.
There you go, Jason.
Oh, yeah.